Hello, good afternoon, everyone. Welcome to today's endocrinology grand rounds. We are very happy to have Dr. Harold Bass talk to us today. Dr. Bass is currently a clinical associate professor in our endocrinology division. He's also president and medical director of Louisville Metabolic and Atherosclerosis Research Center here in Louisville. He's a graduate of UofL Medical School, did his residency and fellowship training in Louisville, and then started his endocrine practice. He was active in clinical practice until around 2008. Over this period of time, he has built a very strong research program, which you can see that building there, the Louisville Atherosclerotic and Metabolism Research Center. He has been very active in doing research in the fields of diabetes, obesity, hypertension, and lipids, and some other areas also. He has done over 600 clinical trials and has co-authored over 300 publications. He has been very active in several societies, having been and I think he's currently the president of the Obesity Medicine Association. He has also served on the board of the Obesity Society. He has been in scientific committees of several of these and in the American Lipid Association. So he is very accomplished endocrinologist, and one of his major areas of interest has been obesity and its complications and how they occur. So today we'll be very happy to listen to his talk on how does obesity cause cardiometabolic disease.
All right, thank you very much. Thank you. Thank you. Well, this is obviously a very big honor for me to be able to present from the University of Louisville, particularly with regard to the endocrine division and such. As Sherry mentioned, I did my fellowship here. It's one of those things like when I went to medical school, a lot of my friends said it was just so difficult to choose, like what sort of specialty to go into. Should it be surgery, medicine? If it's medicine, which kind? There's just so many options. It's hard to decide. And for me, I was exactly opposite. It was only endocrinology. I didn't really care for much of anything else. So there was only one option for me. And as he also mentioned, I'm active in clinical research as well as other societies. For example, vice president of the Obesity Medicine Association, been board of directors of American Society of Preventive Cardiology, National Lipid Association, and such. So it's with that sort of a background where I'm going to talk about how it is that obesity causes cardiometabolic disease. And I think that's important because I just think, particularly if you're an endocrinologist, if somebody asks you, well, how did I get this diabetes? Or how did I get this hypertension? Or how did I get abnormal, they're not going to say lipids, but you know what I mean. How did I get abnormal fats in the blood? I just think at least an endocrinologist ought to be able to intelligently explain how it is that a person went from not having diabetes, hypertension, dyslipidemia, they put on 20 pounds, now they got all three. So there at least needs to be what they call, the elevator pitch. There needs to be at least just some sort of general sense as to the mechanisms. I mean, I'm not a molecular chemist and that sort of thing, but I think there's some basics that I think clinicians should know, and particularly endocrinologists should know. Here's these disclosures. Do a lot of clinical trials. So again, how does obesity contribute to these cardiometabolic diseases and risk factors and these types of things? Okay, the first thing is we can't go anywhere until we get past this. Do calories matter? I just can't explain to you how many lectures that I've gone to, people that are invited because they think they're really good speakers, that will tell you calories do not matter, right? Calories do not matter. Maybe there's some people here that I believe that as well, but I just think that There's nothing about obesity that's going to allow you to be exempted from the laws of thermodynamics, right? And I would just challenge anybody to show me from a strictly from a physics standpoint, how people come. I've even heard people say, oh, well, when it came to obesity, I read that was proven to be untrue, that the law of thermodynamics do not apply to patients with obesity. And that just gets to be very frustrating when you're trying to counsel patients, because patients hear all of these things. Now, don't get me wrong. People who lecture that way get the best ratings ever, right? Their ratings are through the roof because that's what people want to hear. They want to hear that calories don't matter and the types of foods that you eat don't matter and physical exercise don't matter. They want the kind of speaker that will tell people that, because then clinicians and patients can feel more successful, because the alternative is really hard, right? The alternative of caloric restriction and nutritional intervention and routine physical exercise, tough. So I think we ought to have a balance. I'm not saying we should all be physicists and talk to patients like we're physicists, but I do think that we need to have some foundation, scientific foundations for the recommendations we give. Now, having said that, even though it is true that calories in equals calories out, clearly there's more to it than that. There are things that are layered on that. And it has to do with what are those things that affect calories in that maybe people don't know. And here we have just a list of all those things that are working against our patients when it comes to calories in. So I'm not suggesting that that the way that we should treat our patients or educate our patients or guide our patients, just say, eat less, exercise more, see you next time. Okay, that's never going to work, right? I mean, have you ever told a patient that and as they're leaving, they said, I've just never thought of it that way. If I just ate less and exercised more, I mean, I could really turn things around. Okay, that's just the success rate for that sort of approach. Very difficult, very challenging. So again, there are a lot of things that are going on that affect your calories in. There are a lot of things that are affecting calories out. Where I think people get confused is this notion that you eat too much. Okay, that's where I think now you can apply some physics, because it's not necessarily the amount of what you eat, it's what is the caloric density of what you're eating. So if a person says that they want to eat 3 apples a day, I'm pretty okay with that, right? Matter of fact, I'd encourage that. But I'm not sure that I would encourage people to eat 3 slabs of bacon per day, right? So you can see here the serving size and such. It very much depends. The caloric content very much depends on the types of foods. So we have to get beyond that. The other one is, well, the problem I have is that I have a low metabolism. Well, there's been study after study after study that have looked into this. And people who are, there's been an assumption they have low metabolism. There's no relationship to what people believe their metabolism is and what their metabolism actually is when assessed objectively. And the other thing is, if you think about it from a common sense standpoint, if you have, say, for example, a laborer who has the overweight or the obesity, then probably because they have to carry more weight around, they're going to have increased muscle mass. And in addition, they have increase in fat cells. So what is your metabolism? What is your metabolic rate based upon? It's based upon your ability to operate the machinery of your living cells. So the more living cells you have, the higher your metabolic rate. It's pretty simple. So it is more often than not that a person who has the overweight and the obesity, their resting metabolic rate is increased, not decreased, compared to somebody that's matched in every other way except for body weight. Now, there are exceptions. So say, for example, if you had a patient who has a very sedentary lifestyle, say they've had an injury, or they, again, and now they develop sarcopenia, right? They have reduction in muscle mass, then, at least you can say the likelihood of them having an increase in resting metabolic rate is not so much. because again, they have a decrease in muscle mass and such. But overall, as far as the obesity epidemic, it's not because we have a massive group of people out there that have low metabolism. What about stress? Stress certainly does play a role. Stress plays a role in a lot of diseases that clinicians see every day. And it contributes not just to, it contributes again to the most stress can contribute, mental stress can contribute to the most common cardiometabolic and other types of diseases that we see all the time: cardiovascular disease, cancer, psychiatric disease, inflammatory disease, all these types of things. So stress certainly does play a role. There's also this bidirectional relationship between people who have depression and people who have the obesity. And the more they have the obesity, the more depression that they have. So I think we do have to acknowledge that the psychological aspects of obesity, even when we're talking about cardiometabolic disease. And one thing I find to be really curious is if you think about it conceptually, there's really an analogy between ultra-processed foods and mental stress. What I say here is ultra-processed foods are conceptually a nutrient stressors. Well, what do I mean by that? Well, let's just focus on mental stress. One of the real challenges with the chronic mental stress is that it affects behavior. And how does it do that? It does that because it overwhelms the cognitive control. It causes people to pay less attention to their health. It affects homeostasis, the inputs into the hypothalamus. It affects the emotional and memory centers of the brain, and it also can have an effect upon reward. So I'll give you an example. How many times have had people, you've heard, they say they've had a really stressful day at work. What do they say? I'm just going to reward myself and go out and I'm just going to eat, maybe not so wisely, maybe not the most healthful diet. Okay. I'm going to go out and celebrate. Okay. And that makes a lot of sense, except for the fact that how many times you heard people say, not when they have a bad day, but what if they have a really good day? What will they say? Well, I'm going to go out and I'm going to go celebrate. And you think so. The only two times that some people think they eat bad is when they have a bad day or a good day. Well, it's a lot of days, right? So I think we need to be a little bit cautious there. But what about ultra-processed foods? Ultra-processed foods do much of the same thing. They overwhelm your cognitive control. It's the biology. It can overwhelm the attention that people have to the types of foods they know they should be eating. Can affect homeostasis. Can affect emotions. How many times you heard people say they eat ultra-processed foods to treat anxiety or treat depression, right? And then, of course, the stimulating the reward center. Some people have made the analogy that chronic consumption of ultra-processed foods is very much like an addiction. Okay, there's certain, depending on what kind of foods that you eat, can cause you to want to continue to eat those types of foods. So makes it tough because that's not how our brains were meant to be. What our brains were meant to do is to consume natural foods, okay, but then not ultra processed. Eat it in the state in which they were grown, all right? Like if you're talking about plant-based diets or whatever. And there, what you have is you have a balanced homeostatic effects upon the brain, and that's going to be more helpful. But once you start all this ultra processing, where you take out the helpful micronutrients and such, and then concentrate it down where it's basically fat and sugar and salt. Okay, now that may taste good and such, and does all the things to address stress that I mentioned before. But because you're overriding the parts of the brains that would normally apply to homeostasis, that is clearly unhealthful. All right, so with that as a background, how does obesity contribute to metabolic disease? First thing to know, folks, when we treat people with obesity, this is not, we're going to put them on a drug. If they get their weight down 20% or whatever, great, we can take them off the drug. I think as endocrinologists, we just know that that's not how it works. We don't We don't do that with diabetes, hypertension, dyslipidemia. We don't say stay on your statin for a couple of years. Once your cholesterol comes down, you can just stop it. We would never say that. Now I get it. There's the occasional patient where, whether it be diabetes, hypertension, or dyslipidemia or obesity, the occasional patient who really gets engaged in healthful nutrition, turns things completely around with routine physical exercise, and is able to put their diabetes in remission, and is able to put their hypertension in remission, and is able to at least address the triglycerides and such, and maybe even address the obesity. But how often does that happen? Like what, less than 5% of the time? 95% of the time, all of these are chronic diseases, and they should be thought of that way, and they should be treated that way. And why are we concerned about the obesity? We're concerned about the obesity because, first, once you start getting enlargement of the adipocytes and expansion of the adipose tissue, you start to develop deranged endocrine and pro-inflammatory state, right? And that's what contributes, in the global sense, to these cardiometabolic diseases. Or on the other side, you have the fat mass disease, where there are these abnormal and pathological, pathogenic physical forces, biomechanical abnormalities, where you get the sleep apnea, or you get the arthritis, or intrigo, or orthopedic problems and such. So we got to take a dual approach. We got to worry about both of these sides. Now, before I go any further, I want to be absolutely clear what I'm. So as much as my presentation is about what I want to say, it's also about what I don't want to say, because I have to be very careful, because people, they just take off with like some of the things that I present, and then they want to twist it into what they think I'm saying. Well, that's not what I'm saying at all. Let me be 100% clear. Not every case of diabetes, hypertension, dyslipidemia is due to obesity. It's just not. Okay. And we all, as endocrinologists, seeing patients with type 2 diabetes mellitus, don't have the overweight, don't have the obesity, right? We see it all the time with hypertension. Don't have the obesity, don't have the overweight. Same thing with dyslipidemia. So I am not suggesting that we should attribute every person's cardiometabolic disease to that of an increase in body fat, okay? Because it's just factually inaccurate. And it's also unfair to our patients, because I mean, it's to have somebody that, again, that has hypertension, say, for example, and it's due to something other than obesity, to just simply dismiss them and say, well, if you would just eat right and exercise more, then everything would all work out, when we all know that's not true. Okay, that's not fair. It's also inaccurate. It's not in the best interest of patients. I mean, how many times have you had a person referred to you, they have familial hypercholesterolemia, and the family comes in, maybe it's a younger person, the family comes in, mother and father and such, and said, yeah, we met with the doctor, and we tried to follow that diet they gave. We've been trying it for years, and it's just not working. Well, here's a hint. It's never going to work, right? You're never going to get an acceptable cholesterol level in a patient with familial hypercholesterolemia simply by dietary manipulation, okay? And to suggest to a patient, or to suggest to their family, that should be their priority, again, I just think that borders on cruel. So again, we need to recognize other causes for these metabolic disease, not just the obesity. Having said that, adipocytes, very active endocrine standpoint, and they're very active from an immune standpoint. And here's just some of the examples where, again, you get adipocyte hypertrophy or expansion of the adipose tissue, where you get the hypoxia, relative hypoxia, you get intraorganelle stress, and you get these immunopathies and these endocrinopathies and the lipotoxicity. I mean, you look at the endocrinopathies there. I mean, highly endocrine organ. It's just kind of like the gastrointestinal system, right? I mean, that's a highly active endocrine organ, but adipocytes are as well. And then there's so this came about 20 years ago. I was like, well, if dysfunction of adipocytes and expansion of adipose tissue contributes to increased cardiovascular disease risk and increase the development of these cardiometabolic diseases, then why don't we call that that itself a disease, just like we would cardiomyopathy and myopathy and encephalopathy and all these other opathies. Then there's the adiposopathy. And if you think about it, what is cardiomyopathy? Cardiomyopathy is enlargement of the heart cells. They become dysfunctional and you get congestive cardiomyopathy. Well, it's the same analogy the same analogy applies to an increase in the size of the adipocytes, for the reasons I mentioned before, you get dysfunction with endocrinopathies, immunopathies, contribute to metabolic disease. All right, so let's specifically talk about type 2 diabetes mellitus. And again, this should be something, find a way, if a patient asks you these questions, that you can answer them in a simplistic form. And here's about as simple as it gets, is if a patient comes in and they didn't have diabetes, hypertension, dyslipidemia, and now they got all three because they put on 20 pounds, and they say, how did it happen? What you can say is, well, whenever your fat cells become enlarged or your fat organ becomes expansive, it becomes sick, doesn't function well. And when it doesn't function well, you got to have a good functioning fat cells in order for your body to work, and that can contribute to the diabetes. And are there specific examples? I mean, you're not going to tell a patient this, but in your mind, are there specific examples you can think of people who have limited fat, where they actually end up with not improvement metabolic disease, but worsening of metabolic disease? You can think of lipodystrophy, right? So you've got to have functional adipocytes in order to be metabolically healthy. So it's all about the function. So it should be the focus. And your fats and your adipose tissue becomes dysfunctional when you have adipocyte enlargement and when you have adipose tissue accumulation. So anyway, here we go again. Sick fat, you get the endocrinopathies, the immunopathies, increased circulating fatty acids with lipotoxicity, and that develops the insulin resistance, beta cell dysfunction. Here's even more granular. I mean, you would never go over this with a patient, but so again, the disruption of your adipose tissue, you get adipocyte and adipose tissue hypoxia. What happens when your cells get hypoxic? They become inflamed, right? We know this. That's just how the body responds. Maybe they even die. Then there's the lipotoxicity. We have increase in free fatty acids and such, where you have that intracellular ceramide accumulation. We always hear that talked about, whether it be in the liver or in the muscle, ceramide accumulation. Maladaptive mechanical transduction. What is that? Have you ever thought about what has to happen if your adipose tissue is expanding? Well, all that extracellular matrices has to adapt with it. And if it doesn't adapt well enough or rapid enough, where's your excess energy going to go? Where's it going to be stored? Where are those fatty acids going to be stored? Well, a lot of times they go other places, not so good places. So they can go to where? Your visceral fat. You get visceral adiposity, or it can go to your liver and you get fatty liver. It can go to your muscle, get fatty muscle, or it can go around your heart, increase in pericardial fat. So that's maladaptive mechanical transduction. What about intra-organelle stress? We know this. Endoplasmic reticulum don't work as well. Mitochondria don't work as well. And you have this release of these adiposopathic factors and extracellular vesicles. And that's just something that's been more well described in recent years, where again these can transmit all sorts of disruption to other body tissues other than just the adipose tissue. So again, all of this is occurring due to endocrinopathies and immunopathies due to sick fat or the adiposopathy. Taking it a little bit higher up, so again, obesity, the adiposopathy, immunopathies, endocrinopathies, not only are you getting dysfunction of the adipose tissue, but then that leads to dysfunction of the liver, the muscle, the pancreas, the brain, and other body tissues. So fatty infiltration of the liver, I think we all know, is a pretty big deal. It's been a big deal for decades. Fatty infiltration of the muscle has been a pretty big deal. at least within the past 20 years, fatty infiltration of the pancreas is something that's piqued a lot of interest. Brain and such, but the one, I don't even have it up here. Okay, it should be up here. Kidney. That's the one now that a lot of people really focused on, is the increase in fatty infiltration of the kidney. And all of those contribute to the insulin resistance, prediabetes, diabetes. So I'm getting ready to ask you a quiz here. You're gonna have to think. Here's another way to look at the concept of functional versus dysfunctional adipocytes. So you have positive caloric balance. So let's say you look over here at the, let's say we look at where you go through the healthy pathway, where you have proliferation and differentiation of functional adipocytes. So yes, you'll put on body mass, and yes, you still may have fat mass disease, but maybe you don't have the diabetes and the hypertension or dyslipidemia, okay? Maybe you can mitigate those metabolic diseases. So you have an increase in body fat, but maybe mitigation of the metabolic disease. But here, I wonder if you get adipocyte hypertrophy and fat cell dysfunction, now you get metabolic disease with an increase in body fat. So how do we treat this? Well, one is you could reduce the body fat, which is what we're going to talk about. And that's what all the news is now, right? Reducing body fat. But wonder if there's an alternative. What if there's strategies to increase the recruitment of adipocyte progenitor cells to expand adipose tissue by increasing adipose cell number, which might be protective? In other words, can you think of a therapy that you are currently using in clinical practice where you're employing an increase in the number of functional adipocytes in order to treat diseases caused by too much body fat? Yeah, thiazolidinediones, PPAR gamma agonists, right? That's how they work. That's why people gain weight. Now, yes, some of the weight that people gain with the thiazolidinediones, like the pioglitazone and such, some of that's going to be fluid, but a lot of it's going to be due to the increase in the proliferation and differentiation of adipocytes. What about, so let's look at the flip side then. So we say, okay, I get it. Increase in immunopathies, endocrinopathies contribute to the development of the diabetes, but is the flip side also true? That if you have a reduction in body weight, that you actually have an improvement in the diabetes mellitus? Well, absolutely. We see that in clinical practice for your rare patients who really do have substantial weight reduction. And we know this from the bariatric surgery literature, big time, right? That you have what we call remission of the type 2 diabetes mellitus. Now, nobody's suggesting that you've cured anything, right? It's a remission. It's not because you put the weight back on, probably your diabetes is going to come back in. So it isn't like you've just stamped it out forever. But the main dietary, if you're going to put diabetes in remission from diet, the thing that matters the most is how much fat loss did you have? The main contributor to sustained diabetes remission in a weight management program is sustained weight reduction. And the metric that is most correlated with remission of type 2 diabetes mellitus with bariatric surgery is weight reduction. So it goes the other way as well. So it isn't, that's the reason I hate the term. I hate the term comorbidities. I just hate it. Because comorbidities is the suggestion, well, the blood pressure went up and it's a comorbidity. They just happen to go together. The weight went up and we don't know how it happened, but the blood pressure went up too. It's just a coincidence. It's a comorbidity. Folks, what I'm saying is, for a lot of our patients, the diabetes, the hypertension, dyslipidemia is not a comorbidity. It is a complication, okay? It is an adverse consequence of an increase in the body fat. Now, again, I want to be clear, not every case of diabetes, hypertension, dyslipidemia is due to an increase in body fat. I want to make that clear. But for a lot of our patients, it really is. All right, so that's the diabetes. What about the hypertension? Well, a lot of times the sort of nutritional intake that results in an increase in body fat may have other things that have the potential to increase blood pressure. Like a lot of processed foods don't just have an increase in calories, they have a lot of salt, right? Physical inactivity, it's going to contribute to high blood pressure. Insulin resistance, going to contribute to hypertension. Increase in sympathetic nervous system activity. You have an increase in body fat, sympathetic nervous system increases. Renal abnormalities, we talked about that. Okay, renal. There's a suggestion that renal compression from an increase in body fat can increase blood pressure. Vascular abnormalities, where there's increase in adipose tissue surrounding the blood vessels, increase in blood pressure. Adiposopathic heart abnormalities. Again, fat surrounding the heart. We'll talk more about that in a minute. Increase in that insulin secretion, because maybe that results in water retention and such. Sleep apnea. Sleep apnea can contribute to hypertension. And then there are the whole host of other things where you're talking about psychosocial stress and correlation between obesity and hypertension among people of socioeconomic status and that relationship and such. So a lot of reasons why it is that people who have the increase in body fat have the hypertension. And again, if you want to just talk about it from a layperson standpoint, say, well, your fat cells get sick. That's just what causes your diabetes and your increase in blood pressure and increase in your blood fats. Okay. What about dyslipidemia? Again, you're having the increase in the circulating free fatty acids. I have a sort of a divergent viewpoint about adipose tissue than I think a lot of people do. I think a lot of people are of the belief that you have the healthy subcutaneous fat, and then you have the evil, unhealthy visceral fat, and they're just two totally unrelated things. And I just don't see it that way at all. First of all, subcutaneous peripheral adipose tissue can become inflamed as well, right? And it can have endocrinopathies as well. And the other thing is, if you have unfettered ability to store excess energy in your subcutaneous adipose tissue, then you don't develop visceral adiposity. So what is it that causes visceral adiposity to occur? It means if you have limitations on your subcutaneous peripheral adipose tissue. And to me, a limitation in your ability to store energy there reflects a dysfunction of your subcutaneous adipose tissue, right? So to me, all your fat depots are interrelated. They're interrelated to one another. And to suggest that this one's favorable and this one's unfavorable and everything, they're all integrated together. And what I would say is, if you see a patient, so we do lots of DEXA scans for body composition. We do probably 2 or 3 a day not for clinical trials, just people coming in. And I read I have for years, 2 to 3 reports a day. And it is remarkable the amount of wealth of information you can get from these DEXA scans and such. But the essential point is that the variance in the amount of visceral fat is just striking. Okay, it's just striking. So there is a wide variance, I think, in how it is that there's global fat function and dysfunction. It is not uncommon that we see folks of Asian descent who maybe their body weight is up a little or modestly increased, lots of visceral fat. Okay, that shouldn't come as a surprise to anybody here, right? And it's also equally common that if you see our Black patients, particularly Black women, that come in can have a percent body fat of like 40% and have just minimal visceral fat. Okay, so a wide range of fat functionality and fat deposition patterns that's very much dependent upon race, ethnicity, sex, these types of things. So I think we just need to be very careful in only applying body mass index as our only measure for obesity. I think that's a mistake. All right, so here we got the adiposopathic dyslipidemia, where you have a dysfunction of fat, free fatty acids get delivered to the liver, then they get assembled into triglycerides, you get a fatty liver. And then that puts out these very low density lipoproteins. Okay, that's what's most of the time, that's what you're going to find is your increase in triglycerides in your blood. If you see patients with hypertriglyceridemia, of course, we're not talking about familial, we're not talking about like hyperchylomicronemia. Okay, that's a very specific genetic situation. And then those undergo all sorts of exchanges through CETP. As you know, there's a lot of research that has undergone, and a lot of research that we're still doing on CETP inhibitors. But the essential point is this, is when you have these lipoproteins that are in the circulation, they undergo exchange of cholesterol for triglycerides and such. And at the end of the day, when you have an increase in body fat, particularly in patients with insulin resistance and diabetes, what you typically see is decrease in HDL cholesterol, increase in the small dense LDL particles with high triglycerides, right? That's the typical pattern that you see, that we see. And what doesn't change very much, all things, is LDL cholesterol. I think there might be a lot of reasons for that, but that's not really part of this lipid pattern. Okay, so here, what is this lipid pattern, this adiposopathic dyslipidemia? Again, it's elevated triglycerides due to increase in triglyceride-rich lipoproteins, decreased HDL cholesterol, elevated non-HDL cholesterol, or ApoB, and then increase in small dense LDL particles. What about thrombosis? I mean, I think you could already guess this based upon what I said before. You get vascular compression with venous stasis. So if you get venous stasis, increased risk of thrombosis. Obstructive sleep apnea can contribute to thrombosis. Inflammation, hypercoagulability, hypoxia, endothelial dysfunction, insulin resistance, hypertension, dyslipidemia, unhealthful nutrition, physical activity, all contribute to thrombosis. So when I'm starting to look at this, as I have evolved, I mean, I think there was a time you'd say, well, you got your obesity, and then you have your diabetes, and then you got your hypertension, you got your dyslipidemia, and they're all siloed. Nobody ever talks to each other. And then you got, like I said, you got you got cancer, you got heart disease, and each of them are their own separate diseases. I don't see it that way at all. To me, they're all sort of the same disease. They have similar underpinnings to all of them. And if you think of it that way, I mean, I don't think it should be any surprise that the second most common cause of second most preventable cause of, say, cancer is what? Second is obesity, right? Cigarette smoking, being number one. And just think of the recommendation we give to people for heart disease, diabetes, hypertension, dyslipidemia. It's all the nutritional advice and the physical activity advice is kind of the same for all of them. And there's a reason for that, because they're all kind of the same disease. Okay, so what about cardiac disease? Well, you got your direct effects, you got your indirect effects. There's the fat mass disease, where you get what's called HFpEF, heart failure with preserved ejection fraction. We have impaired, we used to call it diastolic congestive heart failure. They don't call that anymore, but the HFpEF, sleep apnea, thromboembolic events, that's the fat mass side. But then there's also the sick fat side, where you have an increase in the increase in the dysfunctional epicardial fat with this increase in inflammation. And this contributes to the heart failure, atherosclerotic cardiovascular disease, dysrhythmia, fatty infiltration of the heart, increased coronary calcium. Very high correlation between increase in visceral adiposity, increase in epicardial fat, coronary calcium. Okay, increase in visceral fat, increase in epicardial fat, same embryological origin, right? So of course they're going to correlate with one another, right? And I would go a step further and say increase in epicardial fat is just simply the visceral fat of the heart, right? Just simply the visceral fat of the heart. And then I don't have time to talk about it, but as I mentioned, correlation between obesity and kidney disease. We were talking about this before we got started. I can't tell you how much research is going on with regard to the anti-obesity medications out there, and we now call metabolic dysfunction associated steatotic liver disease, MASLD, polycystic ovarian syndrome, hyperuricemia. God, again, all of these things, we used to think of them as all separate diseases, but hopefully the point I'm getting across here is for a lot of our patients, I don't see them as separate diseases at all. I think they have some commonality to underpinnings, and that extends to the cancer. As I mentioned, obesity, second most common cause of preventable cancer. Now here is, and here, so you have obesity, mental stress, and cigarette smoking that increases reactive oxygen species. And look at the not so helpful things that happen when you have these body stressors with obesity, mental stress, and cigarette smoking, be three of the most common. And here is specifically how obesity promotes cancer. Obesity promotes cancer. Now here is that's maybe depressing in some ways, but actually I think gives us hope in other ways. Here we have, which is so I was medical writer of this paper here, and it's just so interesting to me. So here in the 1960s, 42% of folks were smoking, right? Only about 13% had the obesity. 2018, it flipped. It's remarkable how much it flipped. Where now you had 15% of the people were smoking, but 42% with the obesity. Okay? So the bad news is, the depressing news is that we went from 13 to 42% from the 1960s to, say the 2020s, right? But how about this? Hopeful. I'll bet if you talk to somebody in the 1960s and said we got over 40% of people that are smoking cigarettes, what can we do about it? Nothing you can do about it. Parents smoke, kids are going to smoke. All the advertisements that are out there, people don't have a chance. And it doesn't matter what's on the warnings we give, people are just not going to change. They did change because we implemented public policies. We got the word out, and guess what? It mattered, right? It mattered. Went 42% to 15%. What's to say we can't do the same with obesity? I mean, I'm optimistic. I think we can, but it's going to take that same sort of aggressive initiative that we did with cigarette smoking. What about sleep apnea? As you know, there's obstructive sleep apnea and central sleep apnea. We're talking about obstructive sleep apnea. Here's the definition. But it causes all these things: worsening of the obesity, congestive cardiomyopathy, atrial fibrillation, stroke, diabetes, high blood pressure, pulmonary hypertension. So obesity contributes to the sleep apnea, which in turn contributes to the cardiovascular disease. What's the best way to assess obesity? I already told you that. BMI is not it, folks. Body mass index. If you look at Black individuals, there are differences. Look, over 90% of the risk factors for all people are going to be very similar. Some would say over 95%, but there are some differences that I think are worthy and are notable. And one would be with regard to visceral adiposity. Okay, Blacks have less visceral fat than do whites. But then there are other things that, so you say, well, that's good. Yeah, that is good. But Blacks have a higher rate of hypertension. Like there's a lot of other stuff kind of going on there too. So I think we need to be cautious. And then here, same thing with females. Females again, decrease in visceral adiposity, increase in subcutaneous adipose tissue. But you might say, well, that's good. Well, that is good. But when it comes to outcomes, once a female has a cardiovascular disease events, for whatever reason that there is, females tend to have a worse outcome. Cardiovascular disease. All right. So when is obesity first treated? I think it depends on how the patient presents. If the patient presents with acute disease, say their blood sugars are 400 milligram per deciliter, or the blood pressure is 220 over 120, and the triglycerides are 550 milligram per deciliter, well, you got to treat the obesity, and that's fine, but you got to treat these other things, like now, right? You don't put that off. But on the other hand, I mean, go back to the days primary care, I think probably everybody in here at one time did some primary care. And if you have a young adult, say they're in their 20s and 30s or whatever, and just recently put on some weight and their blood pressure is marginally increased and their glucose maybe is in the prediabetes range and their triglycerides are say even 200 milligram per deciliter. To me, I see nothing wrong with saying, why don't we first treat the obesity? Let's treat the obesity first before we slap them on a statin and an ACE and an ARB and you know, all these other things. Is why don't we address what could be the underlying cause? Why don't we do that first? And if all the other things come into line, well, then that's a good day. And okay, I guess I should have had it. Yeah. You're talking, I'm not sure.
Well, what I'm saying is you don't wait till somebody has.
Oh, I see what you said. Yeah, that's exactly right. Yes.
You
Yeah,
get-
you see what their risks, yeah, their risks are. That's right. Yeah, wouldn't that be, I mean, now that you say that, I wonder if somebody, I say somebody, I mean, somebody like me should be doing this. Yeah, I'm just wondering if there ought to be a, you know, a similar obesity risk score or adiposity risk score, right? That says when, you know, if you have these sort of risk factors and these types of things, that ought to prompt you to engage in more aggressive treatment. Of course, you know, you have the Edmonton, you know, rating scale and those types, but it's not, but I think there's an appeal to a score, you know, kind of what you're talking about. And you look at very simple, like ABCs, right? I mean, you know, we talk about, I mean, you know, look at things like blood pressure and lipids and glucose, right? Just look at some very simple parameters, don't make it complicated. But those people, being that we're just not a place in society where we can say the 40% of over 40% of the nation needs to be on semaglutide. Okay, we just no, that's never going to happen. But if we could figure out a way to target the people in most of need, then maybe some sort of adiposity treatment risk scale would make some sense, similar to how aggressive are we with LDL cholesterol in patients who have a certain coronary risk score. That's interesting. I've not thought of that.
So behavioral and form of therapy, that's where a lot of the you're talking about, you know, overweight versus obesity,
Yeah.
you know, addressing it in the overweight stage. So question is, how do we?
Yes, and so look, so all right, so the answer you're going to hear from most people, and I think it's the right answer, but is to say, okay, look, anytime that you are treating the obesity, it's got to be a team approach. You got to have a lot of people that are engaged. Now, the bariatric surgery people know this very well, because before you get bariatric surgery, as you know, depending upon your status, you might be seeing a cardiologist, a pulmonologist, and you know, psychologist, and maybe an exercise physiologist and a dietitian. I mean, there's an entire team that's employed, because it can't just be, we're going to take a knife and then everything's fixed. Okay, doesn't work that way with pills, doesn't work that way with surgery. All right. So direct answer to your question is, you know, how do we really approach, in addition, as we are contemplating pharmacotherapy and as we're contemplating surgery, how do we get people engaged in appropriate nutrition and physical activity and other sorts of behavior modification? And I would just say that to have the expectation that that's something that's routinely going to be done by most primary care clinicians or even many endocrinologists, it's just not. It hasn't so far, right? So I think that there does need to be incorporation of more. Now, the obesity medicine specialist folks, and there are more of those every year, do get engaged in those sorts of conversations. But what I would say is, as an endocrinologist, and I've been doing this for decades. If you're saying just strictly from a clinical standpoint, what can you do to help with behavior modification, nutrition, fix it? And here's what I would say is, and there's nothing earth-shattering about this. Have your patient keep a dietary diary, right? I cannot emphasize enough how important that is. And here's what will happen. Or if you've already done this, you know this. You'll say, I want you to keep a dietary. I'm already doing everything like I'm supposed. I'm not saying you're not. So the first thing is you have to employ those motivational interviewing techniques, right? Any kind of argument, you need to set, that needs to go away. You say, I'm not making any judgments of anything. I'm just saying, for my information, in order for me to best treat you, I need data. So if you just write down every single thing you eat and drink except for water, I would like to take a look at that dietary diary. That's what I want to do, right? So then they write it in. So what inevitably ends up happening? People do that. They'll come back in a week or two later, and first thing that happens, they will have lost about 5 to 6 pounds. It's just remarkable, okay? And it wasn't because of the energy expenditure from writing it down, okay? And then the second thing they will say is, I cannot believe this was the time that you asked me to keep a dietary diary, because I never eat like this, okay? I never eat like this. There was a wedding, there was this, there was vacation, all these types of things. There's a lot to be said from a behavioral modification standpoint of just not blame, but accountability. Those are two different things. Blame is counterproductive. Just to say you're overweight because you're just not doing anything that you're supposed to be doing. That's confrontational. It is counterproductive. It is worse. It is better to just not say anything at all. Okay. On the other hand, I have no problems asking people to keep a dietary diary. I got no problems, for example, have them, engage wearable technologies and such, just so I can get that information, to get gathering data. To me, there's nothing offensive about doing that. And I think a lot of times what you find is if you go through your patient's dietary diary, what you'll find is that truly many of the times, much of what they're eating is actually helpful. It's not so bad. But maybe there's just like 2 or 3 things that they're eating or drinking or whatever, where you go, if we could just not do this anymore, okay? You can make big differences with small changes, okay? And I'll just give you an example. Fruit juices. I mean, is that ever going to go away? I mean, people seem to think that fruit juices are going to, they're hell. I mean, look, it wasn't that long ago, maybe a decade or two, where pediatricians and everything were recommending juices for the kids. Do pediatricians recommend juice for infants anymore? I don't think they do. So again, the only way that you're going to know what's going on with your patient, and the beauty of the dietary diary is it is a summary of all their behaviors. So that way you don't have to say, what happened when you got up in the morning? Did you walk to work? You don't have to look at any of those things. You just say, here's the end result of their behavior. You're looking at what exactly they ate and drank. And plus, like I said, if they could use some sort of wearable technology to say, well, they can't afford it, of course you can afford it. I mean, a pedometer costs like what? Like $5? I mean, you can get, it's not a cost thing. You don't have to have the most expensive things out there for simple things. So the answer to your question is, I think that there is a role for behavior modification within the context of an endocrine practice or a busy primary care practice. And it's just a matter of just getting right to the meat of the matter. Now, after that, maybe you do need a psychologist and an exercise physiologist and those types. I'm not saying that you shouldn't consider those things, but I'm just not sure it's practical to say every single one of your patients that you see that has the overweight and obesity, you're going to immediately refer them to a dietitian, to this. Most clinicians are not going to do that. But you can start with the basics. That's how I say it. Yes, sir.
I think, you talked about behavioral modification. Well, one way that cigarette smoking was reduced is that many people came aware that there were these combustible materials that cause cancer and other diseases. And so, this is a much more difficult topic to deal with, but I think you need to convince people that excess fat is toxic.
Yes, that's what I'm trying.
And that's
Sick
much
fat
difficult.
causes the, and see, wouldn't that be something if we had the same sort of messaging that we did with the cigarettes? Now, again, I get it. I'm originally from Southern Kentucky, and a lot of people still smoke there, and they see the warnings will cause cancer, will cause birth defects, will cause heart disease, and people go, got to die something, right? So there's going to be a segment of people here that are not going to listen to any of that. Okay, we've done our best, all right? But we can't ignore the 60 to 70% of the people that would be open to that sort of messaging. So where is the national imperative of educating people about the toxic effects of the obesity and how it contributes to metabolic disease and heart disease, and yes, contributes to cancer? Where is the public imperative to do that? I don't see it. Not like we had with cigarettes. Yeah, you're right.
Sugar can get just much fat tissue. So it's really excess fat tissue that's toxic, and but I don't know that can be conveyed.
What the? Oh no! You were on it. Stay with it. I think I think we absolutely could do that if we put the same amount of effort as we did in smoking cessation and education and those types of things. It isn't going to go away, but you saw with cigarette smoking the kind of inroads that can happen. It's possible, and it could happen with.
But the problem here is that here you just got the cigarette companies. Here you have the vast food industry that's involved in showing.
At that time, the cigarette industry was pretty big.
And
big.
People look at that and say, "Oh, that looks good."
Big tobacco was.
Well, it's true.
Right? They were very formidable. So, yeah.
I learned a few new things today, and you touched such a vast area on metabolism. But and there are many layers of the body system and organ distribution, how they derive the energy from the food we eat. But demographically, if you look, people in the other parts of the world, less developed countries, or particularly say, I'm talking about say Far East region, people are not very obese, but they do have metabolic diseases.
Yeah.
Diabetes is kind of, it's no more a disease of the developed world. Now it's a disease of the less developed world. Diabetes is kind of, going through the roof there. And what I'm trying to say here is, that the one interesting slide you put here, smoking versus non-smoking at 50, 60 years. Although smoking is bad, and I did have some kind of, understanding, but that confirms that smoking affects the metabolism of the whole body, where the fat doesn't get a chance to stay in the body.
Well, I mean that you have adrenergic responses from cigarette smoking, but I want to be clear here. I don't think that the obesity epidemic is because the cigarette smoking went down. I don't think. I think it has more to be what we talked about before. Is you have a massive campaign of advertisements and such, and what they've done is they've extracted the fat. Look, when you eat foods, the reason, I mean, it's the way I look at it, okay? The reason foods have certain flavors and everything is so you will eat them, right? You will eat the food, okay? So that's a good thing for survival, is to eat, okay? And so if it's a little bit sweet, maybe so that helps out, or there's some appeal about the fat and these types of things. And but what we've done is we say, okay, we're going to extract that sweetness, we're going to extract that fat from all these micronutrients and the fibers and all those things that's what the intent was. Those things were put in there to drive you to eat the healthful stuff, but we're going to throw all that away. And we're just going to go right. And in some respects, I'm not faulting people. So let's say, for example, you were let's say, for example, you're the first person that opened up a restaurant. You're a Neanderthal, and you opened up a restaurant, and you said, okay, here's some plant-based food, and here's some meat. Okay, but then another person says, well, I'm going to open up a restaurant to compete with you. What I found was that if I add more salt to my food, people like it better. So they didn't go into it saying, I want to do what's unhealthful for people. Okay, they just said, I want more business, right? And so I think that now you could say big tobacco, I think there's fault there because they tried to convince the American public, I don't know how it is overseas, that cigarette smoking was good for you. Not only did they wash away that it might be bad, okay, but there was a advertising juggernaut to convince people that cigarette smoking was actually healthy. It's a healthful thing for you to have done. Okay. Here, I think there's some to that when they advertise like energy drinks and these types of things. It's going to make you healthier or whatever. But I think the essential point is, I think it goes back to what we were saying earlier. I do think that if we could just apply the same sort of educational initiatives and sometimes maybe even punitive initiatives, like we did with the cigarette smoking. You can't, we got to put it on the label and, labeling and such, and get that education out there. I mean, I think we could make some, and now with the anti-obesity drugs and people see how well people are doing, maybe that's a good way to get the message across. When people see the people that can afford them, that it really doesn't matter. Yeah.
You also mentioned the differences between race and ethnicity, like say,
Yes.
the visceral fat mass in some particular race, less or versus. What is basically defining all these metabolic changes? And I do believe this endocrine imbalance is age dependent.
Is what?
Age dependent, what I think, because it doesn't happen in young population. Endocrine.
Oh, age, yes. Well, you layer it, yes. You layer age on top of it.
Yeah.
Right? And that brings us to this notion. You've probably heard this. People say, well, there's the metabolically healthy with obesity. Right?
Yeah.
Well, that's at a point in time. Right? What people seem to forget is, their chronological effects. So, maybe today you don't have blatant diabetes or blatant hypertension or blatant dyslipidemia, but wait 5 years, right? You layer the chronology, the chronological effects on top of it, and now there is no such thing as the metabolically healthy with obesity, because all you had to do is wait for 5 or 10 years, and now you just exacerbated the problem, or you unmasked the problem.
In the other sense, is the lifestyle basically driving all the changes? Because in the less developed part, their economic status is rising, they are eating more outside the
Yes, right.
Processed food. That is why, so the genes can be changed. But what is common in all of us is our microbiota, whatever we eat, that gets basically determined by your genetics, the metabolites created by those microbial.
Yeah, I think the microbiome, that's an interesting story. And I think there does have some clinical application, but, we've really tried to look into interventions based upon that. And we have no therapeutics that work. Okay. But to your point, particularly when you start talking about people in less developed nations and such, or even people here and lower socioeconomic income and such, genetics is important, no doubts. But what may be equally important is our epigenetics. And that's where we get into a real big problem. Because when you start having increase in body fat or unhealthful nutrition and everything, you are affecting offspring in an epigenetic way. So when I've given presentations, people always want to look like they're like one better than you. You know how people go. And so people will say, when is the best time to intervene with obesity? And so a person will say, well, you got to start when the obesity first starts. That's what you got to do. And then somebody else, they want to be more enlightened. And they'll say, no. You got to start when they're children, right? You got to start when they're children. You can't just wait until they're an adult. And then somebody goes, no, I'm way more enlightened than you are. You need to start perinatally. You need to start, when a woman, when a female is pregnant, you need to, natal care and such. That's where we really need to focus. And then somebody will go, no, it needs to be prenatal care. That's what we need. We need to have, the female getting ready to get pregnant, have implementation of all sorts of appropriate nutrition and attain ideal body weight. You need to do it then. So you can do this all the time. Like, how far back do you go? Well, if you believe in epigenetics have effects generations from now. So the best place to me that I think if you want to combat obesity is treat the grandparents, right? Because that's going to have effects generations to come. So it's all very complex, like you said. There are genetic components, but don't dismiss the epigenetic components, because I think that has a large influence over what happens to people later in life.
Thank you.
Okay, yeah, I better get. Okay, all right, thank you.